To another podcast, If Bones Could Talk by Palmetto Bone and Joint. I'm Dr. James Logging with you again today, and as always, I've got Dr. Jackie Van Dam with me. Jackie, great to have you here again.
Yep, and today we have a great topic that we've been dying to bring to you for a few weeks now, and we're going to be talking about all things about knees.
Yep, and that's a pretty common problem. I mean, I know you see a lot of it, Jackie, as well as I do, but knee pain, obviously a pretty common problem. And so I think, we're going to talk about just a lot of the different problems that you might experience, with pain in your knee and what could be the causes of those. Obviously, athletes, runners, people are pretty active. Knee problems are a big issue that they might encounter. And so there's a lot of different causes of things like that, especially with runners. I know Jackie is a runner, as I am as well. And so we probably had our share of knee pain over time. But there's a lot of different things that runners can get that can cause pain in their knees. So tell us a little bit about that, Jackie.
Yeah, so if you were to come and see Dr. Logan or myself with knee pain and you were a runner or an athlete in general, we sort of try to narrow down the source of the pain. And oftentimes we might give you the diagnosis of runner's knee. The knee is a little bit of a complex joint in that there's a lot of, muscle action on the knee in addition to some tendons and ligaments that can get tight. So if you came in with some knee pain and we figured that it was probably from an increase in your training or running, it may be something as simple as IT band syndrome is one of the more common ones that we see. And the IT band is something I talk about a lot during the day. It's a very long tendon that goes down the lateral aspect of your leg. And unfortunately, that's one of those things that we often don't give a lot of love and attention. So we're really not stretching that. It comes off the side of our hip and goes all the way down to the knee. And it will act on that patella, on that kneecap, and sort of help your knee track appropriately or not.
That's right.
Yeah. So sometimes we'll see pain on the lateral aspect of the patella or the kneecap, and that's from that IT band syndrome. I'll try to teach some patients the exercises in the office, but sometimes we do have to send you to skilled physical therapy for the IT band syndrome.
Yeah, the IT band, like you said, Jackie, I agree with you totally. I mean, it's kind of one of those things it doesn't get the attention that it probably should at times. And it definitely can cause a lot of issues at the knee, especially in runners, and you'll feel it right there on the outside part of the knee. But the IT band, because it does run from the hip all the way down to the knee, I mean, it can also cause hip issues and pain along the length of the IT band. And part of the reason I think a lot of times it kind of gets forgotten about or ignored is because it's hard to stretch. And so even though we teach people exercises, I mean, it's one of those ligaments and that's just really hard to stretch that. And so that's where having, more skilled physical therapists kind of be involved in the treatment of that can really help kind of work some of that out.
Yeah. And sometimes in the office, we'll tell patients to either get one of those foam rollers to kind of roll the side of the IT band, or the therapist may even decide to do some scraping of the IT band where it's a little bit of torture, but we really try to break up that really tight tissue on the side of the knee. The other thing that often comes into play with the runner's knee is you might have heard kind of that snap, crackle, pop sensation going up and down stairs or after you've been sitting for a while. And often we find that is an issue with sort of that cartilage under the kneecap or under that patella.
Yeah, that's definitely a common problem. Runners, but just, people in general. If you notice in that kind of, the Rice Krispies behind the knee, the cracking and popping, a lot of that is due to that articular cartilage on the back of the kneecap. It loses its hydration and it becomes fragmented and cracked and roughened. And so you'll feel that as the kneecap tracks throughout the groove and the femur. And so that can cause a lot of pain and discomfort. Sometimes it doesn't bother people. It's just the noise of it. But then if those areas of cartilage become more or larger and more unstable, then that definitely can cause a lot of pain.
Yeah. And one treatment for that in particular is, I always recommend, especially with knees, a lot of icing. So after you're running, ice. And then as Dr. Logan mentioned, it's that tracking. So we really want that muscle strength around the knee to be strong. And so we'll have you stretch the hamstrings behind the knee and really do a lot of strengthening for the quadriceps in the front. And, one thing that in the last 10 years I recommend a whole lot more is just hip strengthening.
Correct. Yep.
And that really makes a big difference.
Oh, it makes a huge difference. Yeah. The muscular strength, because a lot of the problems people get, I
Mhm.
mean, unfortunately, is due to muscle imbalance and weakness, and then that leads to a lot of these further problems. And
Yeah.
so, strengthening of the muscles can do more for pretty much any problem,
Yeah.
regardless of what it is, just because it provides a lot of stability to that joint. So that's definitely a good idea and helpful. All right, so we've talked about a little bit about chondromalacia. We've talked about IT band syndrome. Patellar tendonitis is probably another one that people will get, runners or just, everyday activity. So let's look at here. I think we got a picture, maybe this one here. And so this is kind of some of the anatomy that you see around the front part of the knee. And you can see in the center, you have the patella, which is the kneecap. And the patellar tendon is the tendon that runs basically from the inferior pole of the patella down to the proximal tibia. And there is a lot of force that's applied through that tendon. And so a lot of times people at its insertions, either on the patella or on the tibia, kids that are still growing will get a lot of issues with the tibial tubercle, which is a growth plate or growth center at that insertion of the tendon. And it's basically just a tendonitis of that, and that's a pretty common problem we see as well.
Yep.
So, a lot of times recommendations for that, again, strengthening, stretching, trying to stretch that tendon out, because most of these injuries occur because of tightness. And so the more you can stretch and strengthen that muscle, the better. We can do braces for those type of things, which that can help. There's a particular one for patellar tendonitis called a Chopat strap, which can help with that some. And so a lot of these things you can try to get better on their own, but obviously if they're not getting better and you've been running and trying to be active and having some of these issues, then please come on in and get a visit with us, and we'd be happy to take a look at it. So kind of moving on, some other common injuries you might see. I think the meniscus tear is probably one of the most common injuries that we see, with regard to knee pain.
Yeah, and I guess as far as the patient that might come in to you with like a medial meniscus, what would you say would be your typical history on that as far as the patient?
Yeah, and it can be really varied across the board. And so some of these tears, they're more degenerative tears. So as people get older, the meniscus tissue is not as healthy. And so, I've seen people who, said, well, I was turning to get in my car and I felt a pop in my knee. And so a lot of it's a twisting type injury, but it could be something just as simple as twisting to get in your car, or you're in the kitchen and you twist to reach to get something off the cabinet and you felt a pop in your knee. So something that simple. It can be obviously in athletes, your football players or soccer players, and they sustain an injury to the knee. But usually it's a twisting type injury. If we look at this picture of the knee here, you can see this is kind of a cutaway view. That patellar tendon we talked about earlier is gone. But these two structures sitting on top of the tibia here in the center are the meniscus, and you have them on both right and left sides. As the bone twists on top of each other, that meniscus gets caught between the two bones, and it usually will cause that meniscus to tear. And so it usually is a twisting injury, but it can be, a significant injury. It could be a fall, or it could be something super simple. So, it comes in a lot of varieties, when you see that.
Yeah. And we see a lot of the meniscus tears, and wouldn't you say there's quite, a variety of, ways to treat it depending on how much is bothering you. So some of these are going to kind of cause your knee to lock in place, and you sort of know mechanically this is locking. You really need to come in and get one of the surgeons to help you. That's kind of a straight to the...
Yeah, absolutely. So if you get a displaced tear, and there's a condition called a bucket handle tear of the meniscus, which is basically where the meniscus tears and flips completely out of place, and then it gets locked in that position. So, in that circumstance, the patient cannot bend their knee, so they can't extend it fully or bend it fully. And so it's kind of locked in that position. In that circumstance, that's not something that you can get better, unfortunately, without surgery. And so that would be something you need to seek, immediate attention for. Come in and let us take a look at it. But, there are other smaller meniscal tears that sometimes can become asymptomatic and don't require surgery. And there's several things we can do for that.
Yeah.
Isn't that right?
Yep. And I think, oftentimes with the smaller tears, I know sometimes it causes anxiety if we do an MRI and we see a tear, but oftentimes with physical rehabilitation and some ice, and we'll do some injections at times, people do recover quite often, fairly well.
Yeah. Just because you have a meniscus tear doesn't mean you necessarily have to have surgery. I mean,
Right.
we've seen a lot where, somebody comes in and they have the pain, we get an MRI, and, the MRI is the only way to diagnose a meniscus tear. So usually we would have to get that to know for certain. While we may suspect it, a lot of times the MRI is definitely necessary. But say you have a meniscus tear, you come in, you see Dr. Van Dam, and she decides, well, let's try an injection in the knee, which I think is a great first step to see how that would do for a smaller tear. Kind of clears the pain up and the pain goes away. Then we just kind of accept the fact that, hey, the pain's gone, then we don't really have to necessarily do anything else. It could come back later down the road, but it may be that it never bothers you again, and that can happen. So I think definitely a conservative option is definitely reasonable, and it depends on the severity of the symptoms, obviously.
Right. And a lot of that with the meniscus tears, I tell patients that it really depends on how you're functioning. So we treat it symptomatically. If the injection and some exercises, make you pretty functional and you're getting through your day without a whole lot of pain, then we won't re-image that. It's just like, call us back if it becomes more symptomatic.
That's correct. Yep. So, obviously if the pain is severe enough and it's not getting better, then usually a lot of times that would require surgery. Typically that's arthroscopic surgery. So this is just kind of a view, of what arthroscopic surgery is. Basically, we're utilizing small cameras and instruments. They're placed through some very small poke holes in the knee. So this is a minimally invasive type procedure. Typically, and this is just a view inside the knee, and this is a meniscus tear. You can see back here, this tissue in between the two bones is pretty tore up. And so usually what you have to do if it's a pretty shredded meniscus tear like that is just to debride out or take out that torn segment of the meniscus. But that surgery can be super successful. The recovery is fairly easy. It's done outpatient. And typically we do that here at our outpatient surgery center here in Chapin. We're able to have that done and go home the same day. And usually you can get back to being pretty active pretty quickly with that type of surgery. Moving on to a more severe injury, obviously would be the ACL tear, which is another common injury we see. And again, pretty common in athletes, football players, soccer players, but it can happen in, any adult.
Right.
Yep. Just if they sustain an injury, a twist or fall or anything like that. The ACL is one of these, you see these X-shaped ligaments in the center of the knee. The ACL is the one that's in the front. It provides a lot of translational stability to the knee. And when it tears, it allows the two bones to slide forward to backwards more than what it should. And so, if that's torn and the patient's having a lot of instability of the knee, unfortunately, that usually is a surgical treatment. So some people will develop, and I think we were talking about this a little bit earlier, people will develop a meniscus tear early in life, and then they don't do anything about it.
Right. And all that instability is just going to lead to a lot of degenerative changes of the knee joint. And so we do recommend with those acute tears, if you're young and you're, fairly athletic or even just want to be very functional, it is best to really repair those.
Yeah. If you had an ACL tear that was fairly unstable and you let that go, and say that happened in your 20s, I mean, pretty early, in your 30s or even 40s, the knee is going to be fairly arthritic and deteriorated just due to the instability. Even though you may have been able to tolerate it during that time, it's going to end up leading to you having to have a knee replacement at a pretty early age. And so usually if we do have that ACL tear, usually we do recommend reconstructing, especially if you're in early age. Let's see. So this is just an illustration of an ACL reconstruction, kind of what that looks like. Typically, we do harvest either your tendon, which we take from that patellar tendon in the center part of the knee, or you can do a cadaver graft. So somebody who has passed away and donated their tendon, that's also a very effective way. It's maybe not quite as effective or strong as what your tendon would be, but it's pretty good. So, unless you're going to be a college, Division I football player, I think a cadaver graft works great for most people who may not be super athletic. But we use that tendon to reconstruct the ACL ligament. A lot of times people will have meniscal tears associated with that too. And so those would be repaired obviously at the same time. So, it takes a little bit of recovery to get over an ACL reconstruction, but it does provide you that stability, keeps the knee from giving way, and then long-term prevents you from getting a lot of worsened deterioration within the knee. So, that kind of brings us to our
Yeah.
last and probably most common problem, and that's just arthritis in the knee. Typically, you're going to see that in the older population, but I feel like even anymore, we see it in patients earlier and earlier. And so, 30s and 40s, patients can get arthritis in their knee.
Yeah, and I guess risk factors for that would include, as we mentioned, with the ACL tears, but really any post-traumatic joint is going to get more arthritic. So if people have had falls, injuries, car wrecks, that joint is probably going to get more arthritis. And then, just as we were saying about the ACL, when you get this arthritis, it's hard when it's an early age arthritis. But, unfortunately, our country, we do have a lot of folks that are overweight, and they're more likely to get arthritis earlier. And
So unfortunately, weight and obesity does play a factor in that.
Right.
Genetics plays a huge factor too.
Exactly.
And it's the health of that cartilage. And so, if you have a family history of, well, my mom and my grandma or granddad had knee replacement, unfortunately, it's probably in your future. There are things you can do to try to help with that. Staying active, like we talked about, staying flexible and keeping the muscle strong does help provide stability to it. Over-the-counter supplements that people can take, glucosamine chondroitin, I think, is definitely a reasonable supplement that is over-the-counter that you can take to try to help maybe slow the progression of arthritis. I think that's a reasonable thing. If you have a lot of arthritic pain, Jackie and Dr. Van Dam and I both see a lot of those patients. Injections can be a reasonable thing to try to help, whether it's steroid or viscosupplementation, which are the gel injections or lubricant injections. Those can help kind of cushion it. There's also stem cell injections, which are, kind of up and coming now, and can potentially help a lot. So there's a lot we can do to try to help calm that pain down, don't you think, Jackie?
Yeah, with the knee arthritis, as Dr. Logan mentioned, the injections sometimes help you get more active. And so sometimes if Dr. Logan says, you're not quite to that point where you might need the knee replacement yet, but you want to get more active, I think there's a place for the injections and therapy and weight loss. And that's one thing we've noticed a lot. If we do injections and help you get a little bit, out of some of that more severe pain, you're really better able to actively participate. There was someone I was mentioning that, hopefully at some point is going to see Dr. Logan for an injection, but she's really unable to participate in any form of exercise to strengthen because of the pain. So we're doing injections for her, and she's going to start aqua therapy and then progress to regular formal physical therapy, and then hopefully at some point see for replacement.
So I think those are great plans to try to help people get active, but before having to go to surgery. Obviously, if the arthritis is bad enough and we're just struggling with the pain, people can't do the activities they want to do, then obviously knee replacement is the next option. Knee replacement is a pretty successful surgery. It does help a lot of people, improves their mobility, helps decrease the pain, allows them to get back to being active, walking and getting out, doing activities they may, couldn't be doing. So, it can help change a person's life. Here at Palmetto Bone and Joint, we do a lot of things that are, different and unique and kind of cutting edge with regard to non-operative treatment, such as a lot of the injections and things we do, but also with regard to the surgery. And so we do a lot of outpatient knee replacement now, especially since COVID, people trying to avoid the hospitals. We've created a really good program for outpatient total joints. So whether it's hip or knee replacement, we do a lot of those here at the Chapin Surgery Center. People are able to have their surgery and go home the same day. Which is really nice. But we also do that surgery robotically. And so the robot is really helpful for the knee replacement. And, when I talk to patients, I kind of tell them it's like having the tires aligned on your car. And you take you put the tire on there. If you just put the tire on and you look at it and say, yeah, it looks pretty straight, it's probably not going to run very smooth, and plus that tire is not going to last very long. Same thing with the way the robotic technology works is that computer and robot scans the patient's knee at the time of surgery. It determines what their deformities are, what the laxities are in their knee, and then it determines what the appropriate plan for that implant is. So it gets the precise precision of implant placement, so that gives the patient better function, better mobility of the knee, a little bit quicker recovery, and then also better longevity to the implant. So it's just a better system all around. It helps get them better function. and it's just a lot more precise, which is really, really awesome for the patient. And we're one of the few places in South Carolina. We were the first outpatient surgery center to offer robotic technology, and we may still be one of the only ones to offer
Now,
it.
how many years have you been doing it now?
So robotic technology is fairly new.
Yeah.
I had a patient ask me this earlier today, as how long has it been around? I started doing it in 2018, so I've been doing it for about 3 years. So, you know, obviously I've been doing knee replacements for almost 16, so long time. But you know, I've seen definitely an improvement in you know, just the precision of how it's done. Things are a lot more precise and a lot better balance. And so as a result of that, you get better outcomes, better function, and just a better overall knee replacement. So yeah, but doing it about 3 years, I guess almost going on 4 years now. And, you know, I've had really, really good success with it. So, you know, a lot of places don't offer it because the robotic technology is pretty expensive. And so, but we felt like here, you know, at Palmetto Bone and Joint, that's something that we wanted to, you know, invest in because we felt it was better for our patients.
Yeah, and I think, you know, just all of the patients that that we share together that have experienced that have been so pleased with the result and the outcomes. And I think it's worth the large investment, really.
Oh, yeah, absolutely. Yeah. So I got, you know, one really good success story, and, you know, just talking about, you know, active people and people wanting to get back. And so, you know, couple years ago, and this was not long after we had started doing robotic technology, I had a patient, and, you know, I used to do a lot of triathlons back in the day. And this patient came in and she said, you know, she was doing a lot of the triathlons when I was doing them at the same time. And she said, you know, my knee's gotten so bad, I can't run anymore, and I can't do the triathlons. And, you know, it's just, that was like her life. She really enjoyed doing it, and it was her stress relief. And she said, you know, I just can't deal with the pain, one, but I'd really like to get back to doing it. Now, typically for knee replacements, we discourage, you know, running on a knee replacement. And the reason for that is because the repetitive, you know, impact of that high impact nature of running can just wear it out. That's not to say you can't do it. And if, you know, patients say, well, you know, I realize it may wear it out faster, but at least I'm going to enjoy that during that time, then, and they're okay with that, then, you know, they can have at it. There's nothing with the replacement that says they can't run on it. So, you know, she had a robotic knee replacement on her knee. And she was determined she was going to get back to running. She was very smart about it. She rehabbed it really, you know, really slowly. She swam and biked a lot initially. And then, you know, once things had kind of recovered to a good point, then she started easing, trying to run a little bit. And I told her way back, I think before her surgery, I said, well, if you ever do a triathlon, let me know and I'll do it with you. And so this past year, it was, I think, February or March, I got an email from her and she said, hey, I just want to let you know I signed up for the Lake Murray Triathlon. And I said, okay, well, I guess I'm doing it too. And so I signed up, and, you know, I started training some and was probably not super prepared like she was. But so I was really proud of her. And we went to the race, and you know, everybody staggers in different times, so you don't know where people are on the course. And so I get out, I'm on the run course, and I hear, hey, doc, and I look over, and here she is, and she's passes right on past me.
Awesome.
And she got, I think she got second in her age group that day. And then she signed up for another triathlon just a couple months ago, and she got an age group award in that one as well. And so, you know, you can get back to doing all those things you want to do. And, you know, she's with a knee replacement. She's out there beating other people who haven't had a knee replacement. And so,
that's a great story.
Yeah, it's a great story. And it just, you know, it emphasizes, you know, if you're willing to put the hard work in to rehab it, you can really get back to doing whatever you want to do, regardless of the activity that you want to do. But so pretty successful surgery. And I think we covered quite a few topics here with regard to knee pain. The gist is there's a lot of variety of problems that are out there. And, you know, it could be one of the many different things.
Yeah, we touched on the surface. We might have to do part 2 with the knee.
Yeah, there's many other things that could be going on. You know, the thing we want to encourage you, if you are having some knee pain and you try some of these things that we talked about, but the knee pain's not going away, you know, the best thing, because you could have a tear or something more significant going on, and if you let that go, a lot of times you can create more damage. So yeah, we encourage you, call us, come in, make an appointment with Dr. Van Dam or myself or any other doctors here at Palmetto Bone and Joint. Come and see us and talk to us about what's going on. You know, we'll get to the bottom of the issue, and then usually we can figure out a plan that's best for you to help, you know, get that pain better and get you back to being active.
Yeah, because knee is one thing where if you're not active and it's hurting so much, it's going to limit everything.
That is correct.
The knees are so important.
It does. It'll weigh on all your other joints.
Yeah.
It sure does. Well, that's about all our time we have here today. Jackie, I enjoyed talking about the knee with you. And we'll be coming back to you again in another couple of weeks with a new topic. And so please tune in. Next time, if you have any questions about anything, go onto Facebook, log in the comments, and just ask us any questions. We'll be happy to answer questions about anything you have at that time. But look for another podcast, If Bones Could Talk, coming to you in another few weeks. Thanks so much for tuning in and appreciate your time. And if you need us, give us a call. Thanks, everybody. Have a good night.
Good night.